Hello, everyone, and welcome to today's webinar, Impacting Sepsis Outcomes Using MALDI TOF, FDA-cleared application for rapid microbial ID direct from positive blood culture. I am Sydney McNeil of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Bruker Microbiology and Diagnostics Division. To learn more, visit bruker.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar is educational and thus offers free continuing education credits. Please click on the continuing education window at the top of your screen to obtain your credits. I would like to now welcome our speaker, Felicia Maida, MT, ASCP, Senior Technologist 2, Microbiology Laboratory, Lahey Hospital and Medical Center, Burlington, Massachusetts. Felicia, you may now begin your presentation.
So thank you for that introduction. I'm just going to reintroduce myself again. So my name is Felicia Maida. I am a Senior Tech 2 at Lahey Hospital and Medical Center in Burlington, Massachusetts. We serve about 3,000 patients daily through our clinic and the hospital. We have almost 400 inpatient beds. We have an ambulatory care center, and we just opened up a level 2 trauma center that runs 24 hours, our emergency department. We are a teaching hospital of Tufts University School of Medicine, and we do have many physicians that have teaching assignments at Harvard Medical School and Boston University School of Medicine. So these are some of the objectives that I will be discussing today. We're going to go over the MALDI TOF and how the rapid identification works for positive blood cultures. I'll talk a little bit about the FDA cleared application versus an LTD, laboratory developed test. I will discuss the cost savings for using MALDI TOF and molecular and how it helps with biochemical testing. And I will also describe how the rapid Sepsityper can directly influence the treatment path therapy of the patients. So in our department, we have a regular routine microbiology department. We have a rapid room for testing where we do rapid throats, COVID testing, herpes, respiratory panels. We do all that on molecular platforms. We also perform C. diff and Shiga toxins in this rapid room. We also have 3 other labs that belong to the microbiology department: parasitology, microbacteriology, and mycology. We have a total of about 21 technologists that work in this particular laboratory. We have a first shift that is from 7 a.m. to 3:30 p.m., and then our second shift techs come in around 3 or 3:30 and work till 11:30 or midnight to cover our second shift. So pretty much the day shift covers the benches. We have a blood bench, a respiratory bench that we also do stools, yeast, and throats on. We have a urine bench. We have a combination of an aerobic, anaerobic bench. We have the rapid room that I described earlier. We have a planting area, and again, our parasitology, and then our microbacteriology and mycology departments as well. So the techs that work first shift, they cover all of these benches during the day. For our second shift, there's 4 technologists that work for the most part, 1 full-time and the other 3 are part-time. They also pull blood cultures. They do perform the Sepsityper. They read urine cultures. They process specimens. They also perform all the rapid testing in the rapid room, and as well as C. diff and Shiga toxins. Our third shift does pull positive bloods. That's part of our core lab, but they do not perform the Sepsityper through the evening shift. They pull the bloods, they'll put them to the agar that's needed, and when we come in the morning, our first shift will take the blood, aliquots, and do the Sepsityper, which we'll talk about that in a little bit. So a little bit about our life before MALDI. Biochemicals in automated instrumentation was always used. So it would take us, between 24 to 48 hours before we would actually get that identification. And anaerobes, as you know, take a little bit longer to grow. So by the time the blood culture goes positive, or any organism, so to speak, not just blood cultures, it takes a couple days to grow, and then using biochemicals or discs or whatever for the anaerobes, it probably takes at least 48 hours before we can get an identification for anaerobes. These are just some of the biochemicals, obviously, that we used to use. Our automated systems. So MALDI came into our laboratory in probably March, I believe it was, of 2015. And by the time we finished our validation and we had the implementation up and running, it was June of 2015. So it took us about 3 months to get this instrument validated with multiple technologists that worked on it. And then we were ready to go in June. So the impact that the MALDI has had on our laboratory has been such an asset. The technologists really rely on this instrument. It's great for rapid same-day identification. We do use this on all of our benches. So it's a great tool that, you have the organism that's growing. You can get it plated on the target, put it in the instrument, and you're getting an identification fairly quickly, at least by the end of the day, where biochemicals and instrumentation before, you're talking at least 24 to 48 hours. You're not sure if the biochemicals work or if it takes a little longer depending on what the organism is. It could take up to that 48-hour total turnaround time. So it's a great tool where it is very helpful for our pharmacy and infectious disease departments. It really helps them to determine what they're going to do for the therapy of their patients. And we have also found that using the MALDI TOF with the rapid identification, it is decreasing the hospital length of stay by about 2.5 days. So I'm going to go over a little bit of the MALDI Biotyper workflow. So we have multiple technologists that work in the laboratory, and everybody is on their own benches, so everybody has their own target that they spot, and each bench is responsible for identifying the plates, the organisms that are on the plates that are in front of them. And, everybody works great as a team to decide who's going to go on the MALDI first and take in turns, but the blood bench always does have priority. That is the first target that usually goes on in the morning, so we can get the identification right out to the clinicians so they can change, treat, use it however they like for their therapy for their patients. So this is what our workflow looked like prior to implementation of the MALDI and the Sepsityper. Positive blood would alert. We would pull it from the instrument, perform our gram stain, aliquot 3 mLs of blood into our tube, read the gram stain, and then decide what plates, biochemicals we're going to use for whatever organism we see with the gram stain. And then we would also make the phone call to the floor provider, clinician, wherever it needs to go to let them know what we see growing in the blood culture. So if we performed a gram stain and we saw gram-positive cocci in clusters, we would plate that to a sheep blood agar. We would add the furazolidine, not great with the words there, disc, and that is to rule out micrococcus. So we do put that on our gram-positives. Then we would also take 3 drops of the blood and put that into a tube coag, and we're ruling out Staph aureus with that. If we were to see gram-positive cocci in pairs and chains, then we are going to plate that to a sheep and a chocolate plate, and we would add an optogin disc on that one. Again, that's just to rule out strep pneumo. We would also take 3 drops of blood and add that to a bioescalin tube and a salt. And again, that would be to rule out enterococcus. So this is so that we would have some type of identification at that 24-hour mark using these biochemicals. For our gram-negative rods, we would plate it to a sheep, a chocolate, a McConkey, and a CNA. If it was from the anaerobic bottle, we would also add an anaerobic blood plate, and that would go into our anaerobic chamber. If we saw gram-positive rods, then that we would just plate to a sheep plate and also a bioescalin tube to rule out Listeria. So at the 24-hour mark, so we're going to let that incubate for 24 hours, we would look at the plate, the growth on the plates, and if we were able to identify the organism at this time, then we would phone that to the floor. We would give them an update to let them know what grew out. If we weren't, then we would have to go to our automated instrumentation, and chances are that's going to take us another 24 hours for the automated instrumentation to give us an identification. Sometimes it takes a little bit longer depending on the organism. So looking at this from start to finish prior to MALDI, we're looking at about 48 hours until we get any type of identification. So now if we move on and we implement our MALDI and our Sepsityper, the workflow is similar to a point. So where positive blood will alert, we will pull it off, we will make our gram stain, we will aliquot our 3 mLs of blood. We will read the gram stain. But here what we would do is now we would set up our Sepsityper and hopefully have an identification, and we're now able to give the identification the same day as the blood culture was pulled from the instrument, therefore bypassing biochemicals and waiting 24 hours before we have any type of identification. So here's just a slide to show you how it kind of works. You have your blood collection system. It goes into your blood culture instrumentation. This is the Sepsityper kit that you see here. And then from Sepsityper, goes onto the target then gets put into the MALDI. And just to let you know, the MALDI, the CA, clinical application side, this is all FDA approved, and they have approved 488 species of bacteria and yeast that are on the clinical application side. So if these organisms are identified, we're able to put these results out into the computer with a confirmed confirmation. Okay, so in October of 2017, Bruker had a Sepsityper that came out, and we did a validation on this. So this was great for us, and we did our own in-house validation. It's on the IRUO side, which is the research use only side. And what we did is we used 40 gram negatives, 40 gram positives, and we did not use any more than 10 of the same organism. This was performed over a period of 3 months, and we were able to identify 93% of the gram-negative organisms and 67% of the gram-positive organisms. And Bruker had stated that the identification system should work at least 70% of the time, which we did prove this was a little under for our gram-positives. But what we did is we continued to monitor it over the year, and of the 708 samples that we tested, we did have a 73% identification rate, so it did perform up to their expectations. In 2019, they did come out with a rapid sample preparation. This eliminated the tube extraction, which made this so much more quicker for us in identification. So due to already having a full validation, we decided we were just going to go with a limited validation in April when we started to use this. So for this one, we just did 5 gram positives, 5 gram negatives. This was a quick validation. It only took about 2 days to get this done, and the identification was successful at 100% of all organisms that we used. The difference between this rapid sample preparation versus the original Sepsityper is because we were doing an extraction, when we were doing our workflow, we decided to batch our blood cultures. We would call the gram stain, but we would batch the blood, and when we had a decent amount, then we would perform the Sepsityper. So the difference is now is with this rapid sample, because we don't have that extraction anymore, we're able to do this as they come in without having to wait and batch, and now it's just done individually as it happens. So the impact of using the Sepsityper, because it's still on the research side, we always would put presumptive ID after the organism. We would have the gram stain within that hour, be able to do a Sepsityper, put the organism in, but we would call it presumptive ID. So pharmacy and infectious disease were still able to see the identification and be able to treat their patients accordingly, and it also did help decrease that hospital length of stay. Some of the disadvantages is that it did take us a little bit to get the validation done. We did have to create our own procedures. We were not able to build this because it was research only. There wasn't any software that Bruker had for the Sepsityper on the research side. And because we put the organisms in as a presumptive ID on the next day, so at 24 hours, when they grew on the media, we then had to use the MALDI to confirm the identification that we got from the Sepsityper on the research side. Okay, so I did speak with one of our infectious disease physicians and asked him if he could give me his thoughts on our Sepsityper system and getting identification earlier. And he said to me, quote, "Patients are put on therapy a day earlier due to the rapid Sepsityper," end quotes. He's, like I said, one of our physicians, infectious disease physicians at Lahey, and he had a Shazam moment, which I will talk about on the next slide. So Dr. M's Shazam moment. We had a positive blood culture that the gram stain showed gram-positive cocci in pairs and chains. We did our rapid Sepsityper, and it identified as beta hemolytic strep group A. So we were like, wow, that's kind of interesting. And then we kind of looked into the patient a little further. We like to look and see if we can try to figure out where they're getting their sepsis from. And we found that this patient also had a wound culture in 2 times 2. So the technologist that was working on this wound culture saw there were very, very tiny pinpoints on the agar and figured they would just re-incubate it for another day so that they could work on it at that 24-hour point. Well, when we discovered that this patient actually had group A strep in their blood, we said, let's pull the plates out, let's see if we can work on it, let's see if we can get an identification. And sure enough, we were able to get an identification, and in both of the wound cultures that they sent, they were group A strep. So it was kind of a really cool thing for us to see in the laboratory and for the information to be given to Dr. M so he could treat his patient, and now he knows kind of where it's coming from, that it was it was in the wound site and now it's in his blood. So it was just a really great moment for us because without that rapid Sepsityper, we wouldn't have known. We would have just reported gram-positive cocci in pairs and chains, and we would have had to wait 24 hours. The wound bench would have waited 24 hours, and, it could have been detrimental to this patient's health. So in 2021, Bruker came out with the Sepsityper Kit US IVD. So this is a kit that now we can use on the clinical side. So this was FDA cleared for the clinical application. So what does this mean for the laboratory? So FDA cleared products are now chargeable. So this is great for us because now that it's on the clinical side, we are now able to charge versus when it was on the research side, it was a non-billable and we were unable to charge for this product. So benefits of it being FDA cleared, I already mentioned a couple, saying that we can bill it now. It was nice because now it's just a limited verification because we already did the major validation earlier. It's on the clinical application side. It allows us to reference that library of 488 species. So now we can say that. We don't have to use the word presumptive ID anymore. We don't have to confirm the ID the next day when the organism grows. We look at it, and if the morphology and everything looks the same, then we know that MALDI identified it correctly. We have now an algorithm, and there's new software that's dedicated to this new kit that we'll go over in some slides ahead. This is the kit. You can see that it has 50 tests per box. We store it at room temperature. The expiration date is a 2-year manufacturing expiration date and 3 months after opening it, which I can tell you we never hit that 3-month mark because with the amount of blood cultures that we have that go positive, we're able to get through these kits quickly. The components inside is the lysis buffer, the washing buffer. It has the microcentrifuge tubes, and then there's a quick guide that if you want to leave that out and have your technologist use that or make a quick reference guide yourself, whatever works for you. We do keep it in the box if the technologists choose to look at that, and we also do have a separate little quick cheat sheet if they want that. So this is how we perform the Sepsityper in the laboratory. We pull the blood off. We have our aliquot. We take 1 ml and we put it into the Eppendorf tube. From there, we add 200 microliters of the lysis buffer. We mix that, and then we centrifuge that for 2 minutes. We then discard the supernatant, and we add 1 ml of the washing buffer. We'll mix that, and then we centrifuge that for 1 minute. We then discard that supernatant, and we should see a pellet on the bottom, and that is what we would use to put on the target, and that's what we use for the identification. Sometimes we don't always see that pellet, and we have used we keep like a little bit of the aliquot of the fluid on the bottom of it. We'll pull off the supernatant but leave a little bit of the fluid, and we actually have been able to get an identification from just that fluid even if it doesn't have the pellet in there. So, you know, we try it anyways, and then if it doesn't work from there, we can continue on and use the extraction, and we will 9 times out of 10 get an identification once we go to the extraction. But most of the time we will get an identification at this point in the process. So the workflow flexibility, again, the bottles are stable for 24 hours once they come off the instrument. So you have up to 24 hours to aliquot and run your Sepsityper. This is just how we do it here in our laboratory, and of course, you know, from laboratory to laboratory, it can be used differently. But we perform our gram stain, we subculture it, and then we aliquot it for the Sepsityper. Again, there's 488 organisms that you're going to be able to use for identification to match up, and the pellet is stable for 1 hour. The other thing is, if you can get that pellet onto the target and you put your matrix on, then that is stable for 24. So even if you're not able to run that target, if it's the end of the shift or something happens or the MALDI goes down, God forbid, as long as you put it on the target and you put the matrix on top of it, then you're good to go for 24 hours. And then once we get our identification, I haven't really talked about this yet, but we'll get into this a little bit more. It can be reflexed to molecular testing for any resistance markers if needed and if you have that molecular testing in your laboratory. So there is a dedicated Sepsityper software now that it is FDA approved and it's on the clinical side. You would put in the patient sample, or you can scan it in. We would then change the standard to Sepsityper, which is in a drop-down. I'll show you that in the next couple of slides. And then we have our the Sepsityper algorithm is applied. It would identify if it's a mixed culture alert, and it shows you the different scores, and that will determine whether it's a reportable identification or not, which I'll talk to you about in the next couple of slides. So here's the scoring that I was just speaking of. As you can see, a high confidence identification is a 1.8 to a 3.0. We will see a color green on the screen. A 1.6 to a 1.79 is low confidence, and then anything below 1.6, we really don't take that into consideration at all. So what ends up happening is as long as we get that 1.8 or higher, we can report that organism out. We have had situations where we're at that 1.79, the 1.78. So if that gives us an identification there, we can try and move forward to the extraction and see if we can get it a little higher. If unfortunately we can't, then we would just leave the gram stain result in the computer. But we do have infectious disease rounds where ID comes down and we do update them on their critical patients, any positive blood cultures. So at this point, we would verbally let them know that the Sepsityper gave them an identification of X, but we can't put it in the computer. So that way we can at least help guide them and give them direction. 99% of the time, if it's in that yellow and we get that low confidence, we are on the right track, but it's just not something that we can confirm and we're positive with, so we cannot put that information into the system to get into the patient's chart. But like I said, we will let infectious disease know that, you know, on the QT this is what's going on, but we can't put it in the computer, and, you know, they're very grateful that we even have that information for them. So this is what the screen would look like if you had a mixed culture. This one is showing you that the Staph aureus is a 1.98, but there's a Corynebacterium in there at a 2.5. So what happens with a situation like this, if we run into something like this, we have our technologists see a senior tech 2 or our manager. And what we would do then is we would look at the gram stain. If the gram stain was only gram-positive cocci in clusters, and we got this 1.98 Staph aureus, we would sign it out as a Staph aureus. If we saw that it was mixed by looking at the identification from the MALDI and then reviewing the gram stain and we see maybe some gram-positive rods in there, then we probably would not do any identification. In our laboratory, if it's a mixed culture, so if we see polymicrobes in the gram stain, we do not put it on Sepsityper. We really only will use the MALDI and the Sepsityper if it is just one organism in the gram stain. Other places may do it differently. This is just what our algorithm is, and this is how we've set up our procedure. And like I said, typically we do not run into this. I think maybe we have seen this once since we've been using this system. So again, the scoring of this, it has to be above 1.8. And if there is no identification, I kind of talked about this, we would go into that full extraction. And 9 times out of 10, it will work, but there definitely are times that it's not going to. Again, you know, it's a 70% identification rate. Okay. So here's a case where we ran the Sepsityper, and as you can see, it says no peaks, and under the score, it says 0.00. So this would be something where this was the rapid Sepsityper, so there was no extraction. We would do the extraction on it, and then we would see if we could get those numbers higher. If we can't, then this is a case where we would put it on our molecular instrument and get the identification off of our molecular instrument. So now this next slide, what you can see is there was no match, so no organism identification from the clinical application side, but if it does find something on the research side, you will see that come up as an unvalidated result. And in this situation, we had a no organism identification possible, but yet on the research side, it gave us an identification of a bacillus, which was greater than that 1.8. So in this situation, what we have done, because we've validated the research side, we are able to put that in as a bacillus species, not anthracis, and we would just use that code presumptive ID because it is on the research side. So our algorithm in our hospital, when we perform our Sepsityper, is in these next few slides. So I'll talk you through them. They may seem a little confusing, so bear with me, and hopefully you'll be able to follow my direction. So when we have the first bottle of a set that is positive with gram-negative rods, gram-positive cocci, or large gram-positive rods, we automatically do a Sepsityper. If the second set turns positive, so if there's two sets that are drawn on the same day, the first set goes positive, we do our Sepsityper. If the second set turns positive from the same day, we will not do a Sepsityper. We're assuming that it's the same organism from what we just identified from the first set, unless it's a coag-negative staph. In our hospital, our algorithm states that we look at the species of the coag-negative staph to decide whether we're going to do an AST on it or not. So therefore, we look at the sets and we determine from there whether we're going to do a Sepsityper or not. If it is a new bottle from a different day with gram-negative rods, we will set up the Sepsityper because we want to confirm that it's the same gram-negative. If it's gram-positive cocci, we will not set it up unless, again, it's that coag-negative staph and it's greater than 3 days old. And then if it's a gram-positive rod, we do not set it up. So we really focus on that very first set, and then if it's the next day, depending on the organism, will depend on how we're going to use the system. So just to show you how this Sepsityper kit is used as a frontline method, we make the gram stain, we do the Sepsityper, read the gram stain. So as the gram stain is drying, we're setting up the Sepsityper. We read the gram stain. So now we have an idea of what the organism is going to be. We will hopefully get the identification from the sepsi. And if we can get all this done within an hour, then we can phone it and let them know what that identification is. If we know it's going to take us a little longer than an hour, if something comes up, if we have too many blood cultures, if something just gets in our way, then we will automatically call that gram stain and we will not wait for the Sepsityper. One of the great things about the Sepsityper is if we're reading our gram stain and we're not sure, is it gram-negative rods, is it gram-positive rods, is it a gram-variable rod, then we really do rely on the Sepsityper, and that really can help us give us a good guidance as to what this gram stain is. And there have been quite a few times that we have said, let's just wait and see what Sepsi gives us for an ID, and that way we know what the actual gram stain is. So another great feature of what that Sepsityper can do for us as far as identification of organisms. And then depending on what the organism is, will depend on whether we're going to reflex that to our molecular testing, which I will show you in the next slide. So our algorithm, again, for gram-positive cocci. So we have a Sepsityper that gives us an identification of Staph aureus, Enterococcus, or the combination of Strep mitis pneumo. We will automatically put that on our molecular instrument because we're looking for any gene markers. So whether it's a VRE, we're looking for MRSA, And then depending on that identification, if it is a VRE, if it's MSSA or MRSA, between the hours of 9 to 5, we do page our pharmacy, so that way it will give them a heads up as to what the organism is, and they can continue with therapy or discontinue therapy as need be. If the Sepsityper does not give us an identification, we will do the extraction. If we still do not get an identification, then we will put it on our molecular instrumentation to see if we can get an identification. If it is a coag negative staph, so Sepsityper gives us any type of coag negative staph, then we just stop there. There's no need for us to put it on our molecular instrument, and we will page pharmacy at that point to let them know that it is a coag negative staph. If it gives any other type of identification, as long as that score is above 1.8 and it's not an organism that we would be looking for gene marker resistance, then we do not put it on our molecular instrument. Again, we use our molecular instrument for identification if we can't get the Sepsityper to work and for any gene marker resistance. So for gram-negative rods, same type of algorithm. Perform our Sepsityper. There's no identification for Sepsityper. It goes right to our molecular instrument. To the slide, if you look at the box on the left, the right, however you're looking at the system, if any of those organisms are identified by Sepsityper, we automatically put it on our molecular instrument, and we're looking for that gene marker resistance. If we find any resistance markers, then we do page pharmacy. If there are no markers, then there is no page to pharmacy. Any other identification that is not in that bubble that you see, we do not go any further. It does not go on the molecular instrument. And again, it has to be above that 1.8 in order for us to identify it and put it into our system, and then we do not go any further. So just a quick overview of what we did for our verification using the Sepsityper on the CA side. Again, just very limited, 15 gram positive, 15 gram negatives, 10 anaerobes. This took us about 4 weeks to get this validation done. We had 31 of 40 were concordant with the expected results, but 9 of those 40 did not give us an identification. So we excluded those from our data due to there is no expectation that this test will provide identification 100% of the time. So therefore, our scores were above that 70% again. So here are some statistics from April to June. We did 194 Sepsityper IDs. Of the 194, 170 of them were identified. So again, 87% identification, so well above what Bruker states. And then just a little bit of data just to show you how it's worked in our hospital. So the number of Sepsityper identified that we had to put on our molecular instrument for resistance detection, so there was 96 organisms. So that was a 49.5% identification on Sepsityper. That 49.5% were sent to the molecular instrumentation, sorry. For the number of Sepsitypers that were sent to molecular because there was no identification, there were 24 organisms, so that was a 12%. 12% of them were sent. And then for the number of Sepsityper identified on the number of Sepsitypers, the number identified by Sepsityper that we did not have to put on our molecular platform was 74. So 38% of our organisms did not have to go onto our molecular instrument. I know that was a little confusing, but hopefully looking at the chart, you'll understand what I was trying to get out of my mouth. So this gave us a total savings on our molecular test kits of $11,000, a little over $11,000 that we saved over a 3-month period. So going back to the other chart, if you saw 74 did not have to go on to our molecular testing at $150 for a price test that we use, or price per test, I should say. So you can see the savings that we had just over a 3-month period. So lastly, I'm just going to get into a few case studies just to show you how this has impacted us here at Lahey. So the first case study, we had a blood culture flagged positive. The gram stain result was gram-negative rods. We did a Sepsityper, and we ended up with B. frag. Well, as you know, B. frag is an anaerobe. When we reported this, we reported it out as gram-negative rods. Now, we can't say that it's an anaerobic gram-negative rod because at this point we do not know. So it was gram-negative rods. Then we were able to perform the Sepsityper. It gave us the B. frag result, which we were then able to update. We were able to update it in the computer, in the patient's chart, and therefore ID Pharmacy was then able to change the antibiotic therapy to an appropriate antibiotic for this particular organism. So again, typically gram-negative rod, they're going to choose one type of therapy for a gram-negative rod, and as you can imagine, if it's an anaerobe, they need to choose a different one. So this was great for them to see, definitely helped provide in patient care. The next case study was positive blood culture flagged, and this one was gram-positive cocci in clusters, and it was suggestive of staph. So this is how we report it. If we see gram-positive cocci in clusters, we always say suggesting staph if that's what it looks like to us. Again, performed the Sepsityper and came out with Aerococcus urinae. So you can imagine how surprised we were when this result came out. We're thinking it's going to come off as a Staph aureus or coag-negative staph. So to see that it was an Aerococcus, that really blew a lot of our techs' minds. We were just like, oh my God, this is just amazing. And Aerococcus is one of the organisms that is not on our molecular platform. So even if we put it on there, we still wouldn't have been able to identify it. So this was great because here we are, and ID and pharmacy and the patient's care team is thinking they're dealing with some type of a staph, and now we're able to give them this identification that it's an Aerococcus, which is great because, again, now they can change that antibiotic therapy. So without Sepsityper, this patient would have been on staph therapy until the next day when we said, oh no, this is definitely not a staph. So again, just great things with the Sepsityper. And then the last one, it flagged positive. It was gram-positive rods. So again, that goes into the system as gram-positive rods. We performed our Sepsityper, and again, amazement, it ended up being an Actinotignum shalei, so formerly known as an Actinobaculum shalei. So this one was kind of interesting. It's not a bug that we typically see in our positive blood cultures for sepsis. So we did look a little further into the patient's history, and we noticed that we did have a urine culture that did have greater than 100,000 CFUs per ml pinpoint colonies. So because the colonies were so small, the technologist said, I'm going to reincubate this plate for tomorrow, and then we'll see what it looks like. So by having that Actinotignum shalei identification from the Sepsityper, on day 2, the colonies were a little bit bigger. They were able to use the MALDI on the colony, and they also confirmed that the Actinotignum was in the urine. So this was great because we were able to inform the clinician that the positive blood had the Actinotignum. The urine did have greater than 100,000, but it was pinpoint. But at least now the clinician is able to connect the dots and understand where the sepsis is coming from. So just some great work that we were able to do using the Sepsityper and providing the clinicians and pharmacy with all the information that they need to be able to help treat and change therapy for these patients as needed. So in conclusion, as you've heard me discuss throughout the talk, the Sepsityper kit is an extreme asset for us here at Lahey, used as a frontline method for our positive blood cultures. The results are determined within minutes. I mean, we're talking, a good 20 minutes compared to the 24 to 48 hours once that blood culture flags positive. Due to the FDA clearance, we are now able to report 488 organisms and not have to have a presumptive ID. We don't have to go back the next day and do a MALDI to confirm it. It definitely provides actionable results for our clinicians in a timely manner, as well as our pharmacy. It's decreasing the hospital length of stay by 2.5 days. We definitely decrease the amount of biochemicals that we order, so this is another significant savings, and as well as the savings that we have using molecular. And then it is a great tool for our antimicrobial stewardship. And these are just the products that I discussed, just a quick review. So it is the MALDI Biotyper system and the Sepsityper kit. We do use it on the clinical application side. And that's all I have to say. It's a wonderful tool for our hospital. We don't know what we would do without this. We love it. It's great. I just cannot say enough about this. So I thank you for your attendance. Thank you for letting me come today to discuss the MALDI TOF. And at this point, I will take any questions that are out there and do my best to answer them.
All right. Thank you, Felicia, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, does your lab use any sequencing assays for ID? For example, in those cases where the MALDI is not adequately discriminatory?
So the only reason we would have a discriminatory result would be if it's lower than 1.8. So if it is lower than 1.8, like I discussed in the presentation, we would do an extraction. If the extraction didn't work, then we would put it to our molecular instrument. So at that point, if we don't get a result from that either, then we just leave it in as a gram stain result and we wait for the organism to grow the next day.
Perfect. Thank you. Our next question is, you mentioned 70% correct identification, but later 87%. Have you improved your rate of identification as you worked with the kit?
We have. So as the technologists became more comfortable with it, we did see an increase in that percentage rate. We also figured out what we could do to tweak it, what would work best for us and what wouldn't. Sometimes, just using that extraction actually increased the identification. A lot of times we will see gram positives give us a little bit more difficult time, so we will have to go into that extraction method versus just doing the straight rapid.
All right, thank you. Our next question is, we tried the FDA-approved kit and had very poor results for gram positives, 30% ID. Did you experience the same? Do you have any tips for us?
So unfortunately, we did not. We actually had very good results. And like I said, I think it was because we did the Sepsi, and if we didn't get it from the rapid, we went into the extraction. I'm not sure if you did the extraction method with it. But once we did the extraction method, then we did have, decent results, enough to get us over that 70% mark.
All right, thank you. Our next question is, can a generalist MLT be able to perform this?
Yes, absolutely.
Perfect. Next question, how do we manage contamination rates?
Contamination rates as far as the Sepsityper, I'm not sure. We have a technologist that looks at our blood cultures and looks at contamination rates. So that really is more dependent on our blood cultures, not the Sepsityper. I can't really speak to the fact that we've had contamination rate for the actual Sepsityper kit and performing the test, if that answers the question.
All right, thank you. Next question is, how do you transfer the pellet from the microcentrifuge tube to the MALDI target?
So there's a couple of different ways you can do it. We usually just use the toothpick that we would use to spot with the regular organism. Sometimes if it's really liquidy, then we'll just use that 1 microliter, the pipette that we would use for putting the matrix on it. So we do it either way. We can use the toothpick or we can use the 1 microliter pipette.
Wonderful, thank you. Next question, what issues have you encountered with the kit? What percentage of mis-IDs have you seen?
I can honestly say we have not had a misidentification with this kit. We haven't had any issues with the kit. The only issue that we would have is if we got too low and we didn't notice it and we didn't have it on order and we needed to order it quickly overnight. That's pretty much it, but we have not had any misidentifications.
All right, next question. What percentage of samples need extraction?
That I don't know off the top of my head. If I had to guess, maybe 20%. It's for our laboratory and our technologists, it's really not a high number.
All right, thank you. Next question. What's the advantage of MALDI over target-specific amplification by PCR?
So that just goes to looking at the cost savings, which was in my slide.
All right, thank you. Next question. I might have misunderstood the rationale, but can you clarify again why the 9 non-identified specimens were excluded during your verification of the Sepsityper verification?
So they were excluded because they weren't misidentified. We just didn't get any identification. So therefore, we took those out to look at our numbers because we're not going to put something in where it doesn't have any type of an identification. If it gave us a misidentification, then it would have been included in the numbers.
Perfect. Next question. Have you had any supply issues?
No, just like I said, if we forget to order, that's really the only supply issue that we've ever had.
All right, next question. Did you identify any yeast from the blood cultures?
That was the only issue that we had, so we do not use it for yeast. If we do get a yeast, we will go straight to our molecular instrument. All
right, next question. I have heard that the MALDI has difficult differentiating S. mitis versus S. pneumo. Have you seen this? Are there any other related issues?
Yes, we have run into that, and that we will see. So if we run across a strep mitis / strep pneumo, we will not do anything with it. We will leave it in the report as gram-positive cocci in pairs and chains, suggestive of streptococcus, and then we wait for that to grow on the plate the next day, and we will put that optogen disc on, so we will have an identification after 24 hours if it is a strep pneumo.
Perfect, thank you. Next question is, what is the % of mixed contaminated blood cultures in your lab?
I don't have that off the top of my head.
All right, let's see. Next question. During your validation, did you run into any misidentification, and how did you handle it?
I can honestly say we did not have any misidentification. If anything, we just had low scores.
All right. Next question. What issues have you encountered with the kit? What percentage? Oh, I apologize. I believe we asked that question already. Let's move on to another. This one says, do you have any suggestions to provide a laboratory just starting the validation process for CA Sepsityper?
Suggestions. It's hard to say. I guess it would be whatever works for you. We gathered the organisms that we wanted to see if it was going to identify them, and then we had multiple technologists work on it so that we knew different people would be able to use this. We didn't want to have it to just be one certain technologist doing it. Using the extraction kit in the formic acid is key because some of the organisms do have that thicker cell wall, and without that formic acid to help break it down. Sometimes you won't get the identification, so formic acid does have a lot to do with the identification. You could reach out to me if there's questions that you have, and I could help guide you, or, help you get through or figure it out, just not sure what it is you're looking for.
Perfect, thank you. Next question, which gram-positive bacteria is having trouble with good identification?
Sometimes our Staph aureus will sometimes coag-negative staph. It's really just those two tend to give us that issue. So like I said, we do, with the formic acid, that does help, but sometimes it doesn't help enough that we have to do the extraction on the staphs.
Perfect. Next question. How far is this system good at identifying fungal sepsis?
We actually just got through validating that for fungal organisms. We are not using it for fungal sepsis. So like I said, if we do get a yeast, that goes straight to the molecular instrument, but we just validated our MALDI TOF for fungal elements in our mycology lab.
Perfect, thank you. Next question. Are the ranges different for the IRUO acceptable cutoffs from the Sepsityper cutoffs?
No, they are not. They're the same.
All right. Next is, do you use disposable targets or reusable targets?
We have the reusable targets that we use in our main lab, but we actually do use this for mycobacteriology as well, and the mycobacteriology uses the disposables. So we use both. Perfect.
All right, it looks like we have a couple questions left. Next is, what happens if blood cult is positive after 5 p.m.?
So like I said, our second shift will run the Sepsityper. So our Sepsityper will get run up until 11 p.m., and then anything after 11 p.m. will be held for us in the morning. So if the bottle goes positive, again, like I said, you have that 24-hour period. We will take the aliquot in the morning when we come in at 7 a.m. and run the Sepsityper.
All right, wonderful. We have one final question. Have you seen 3 organisms in the same bottle, yeast, GPC, and GNB, and how did MALDI report it out?
So we have had polymicrobes in our bottles, but like I said in the presentation, that is not something we would put on the MALDI. So that would just be something we would just report out the 3 organisms that we see for the gram stain, and we would wait and see what grows the next day, and then we can use our organisms and put those on the MALDI TOF the next day for identification.
Perfect. Thank you. Well, thank you again, Felicia, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Bruker Daltonics, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.